Hello everyone and welcome back to Human Physiology. Now that we've had a chance in the previous video to discuss how blood pressure is measured, let's talk a little bit about the sorts of factors that determine blood pressure and also how blood pressure is regulated in the body by use of the autonomic nervous system. So, given what we've already talked about with Poiseuille's law and the different factors that regulate and determine blood flow through a blood vessel, let's talk a little bit about the same sorts of factors and how they impact blood pressure itself. Now, number one, the most important factor that's going to help determine blood pressure through the systemic circuit, namely the arteries, is going to be your cardiac output. At the end of chapter 19, we talked all about the different ways that cardiac output can be regulated by the autonomic nervous system, namely regulation of the heart rate and the different ways we can regulate the stroke volume. So those all still apply here. Whatever you do to the cardiac output, you're going to see an effect on the blood pressure. So the idea here is very simple. As your cardiac output increases, there's going to be more blood being pumped by the left ventricle every minute. And as such, with more blood coursing through your arteries, there is going to be a higher pressure on those arteries. In a similar concept, the amount of blood that is in the circulation is also going to impact the blood pressure. If there's more blood occupying the arteries, then the pressure there is naturally going to be higher. We discussed blood viscosity when we talked about Poiseuille's law and blood flow. The same thing applies here. The more viscous the blood is, the higher the pressure is going to be necessary to push it through the vessels. But thankfully, this is not something we're going to have to worry about too much, as this should remain mostly constant unless you're dealing with a drastic change in the composition of the blood, such as an infection in which you would have higher counts of white blood cells, or dehydration in which there would be less water and the blood would become even more viscous. Compliance of the blood vessel is going to be an important determinant of blood pressure. We talked in an earlier section of this chapter that veins and arteries have a slightly different composition in terms of the wall of the artery and of the vein. Veins, because they're naturally more elastic and a little bit thinner in terms of their wall, they end up being more compliant than the arteries, so they can actually expand to accommodate a greater volume of blood. So the more compliant a vessel is, the better the blood flow is going to be, and as such, we can get away with a lower pressure in those vessels. So again, that helps to explain why the pressure in the arteries has to be higher than in the veins. And then finally, also with Poiseuille's law, we also talked about vessel length and diameter, talking about resistance to blood flow. And the idea there is still the idea here. The longer the vessel is and the narrower the vessel is, the more resistance to flow there is going to be. So when it comes to the diameter of the vessel, that of course is still going to come down to vasoconstriction and vasodilation balances. If you look at some of these graphs here, you can actually kind of infer a lot of useful information about how blood flows through different types of blood vessels, starting with the arteries and then ending up in the vena cava as blood returns back to the right atrium. So if you look at vessel diameter, none of this is going to be very surprising. We talked about all this in the first video of this chapter. Veins by far have the largest diameter, with arteries kind of tailing closely behind. And then as blood kind of gets towards the middle with the arterioles, capillaries, and venules, the diameter gets lower and lower and lower, meaning that there's going to be more resistance to blood flow in those areas because the diameter is less. But as we're going to see here, if you go down to the bottom right here and you look at the velocity of blood flow, you'll see that there's also a very similar effect here in terms of diameter and how fast blood is able to move through those vessels. You might end up thinking that it's kind of a problem that blood slows down so much when it gets to the capillaries, but it's actually quite the opposite. It's actually very important for the blood flow to greatly slow down when blood is moving through capillaries, because we have to provide adequate time for gas exchange and nutrient exchange to occur. If the blood's moving too quickly through there, then we won't be able to accomplish that. The blood pressure graph on the far left, of course, should make sense. We talked about this sort of thing in chapter 19. The arteries experience the highest pressure, and then as blood naturally moves the correct direction through the circulation, the blood pressure is going to continue to drop. The top right graph looking at cross-sectional area of a blood vessel is very interesting because you're actually going to see an inverse relationship between cross-sectional area and velocity of blood flow. So you're going to notice here that the vessels that have the lowest cross-sectional area, the arteries and the major veins, are going to experience the highest rate of blood flow. The higher the cross-sectional area becomes in the capillaries, venules, and arterioles, then blood flow at that point is going to greatly slow down. Okay, so before we get into autonomic control of blood pressure, let's talk just a little bit about an important pathophysiological case study, that being atherosclerosis. So we've mentioned atherosclerosis in a previous chapter when we discussed things like myocardial infarctions. What sorts of things could actually block a coronary artery and prevent the cardiac muscle of the heart from getting an adequate supply of blood? Well, atherosclerosis is a perfect example. So atherosclerosis at the root cause is caused by the blockage of major arteries by fatty accumulations called plaques. Plaques usually consist of a combination of fats, cholesterol, and a type of cell called a foam cell. Foam cells are actually macrophages that have become, in a basic word, sick because macrophages, as luck would have it, really like to patrol through the blood, and one thing they really like to do is they like to pick up and glom onto any fats that they find. If there are too many triglycerides and other lipids in the blood, macrophages will pick these up, and when macrophages do this, the macrophages become essentially very sticky, and they like to stick up against the sides of blood vessels. So when they do that, that's going to lead to a nucleation event in which more macrophages become foam cells and then stick to the plaque that originally started, until you eventually get to the point where you have a large plaque that has effectively reduced the diameter of the blood vessel, which, as we have learned, is going to restrict blood flow. So another issue here, in addition to cutting off blood flow, according to Poiseuille's law, is that these are going to harden the artery and reduce the compliance of the vessel, meaning that arteries are going to have a harder time holding the same volume of blood that they otherwise would. So that's also going to impact blood flow as well. Now, you might be wondering, okay, well, the problem here is clearly that there are fats and lipids being transported through the blood, so why don't we just get rid of those? Well, it's actually important that these fats continue to be transported through the blood. So let's talk a little bit more about the root cause of atherosclerosis. So as you, I'm sure, are aware from a previous chapter earlier on in the semester, lipids are hydrophobic compounds, and they ordinarily will not be able to be dissolved in the aqueous environment that is the blood plasma. So therefore, in order for these to be contained within the blood, they need to be carried around by carrier proteins. These carrier proteins are called LDLs and HDLs. These are called low-density lipoproteins and high-density lipoproteins. As such, they bind to these hydrophobic fat molecules and transport them throughout the blood so that the hydrophobic molecules don't have to interact with water. So they transport these fat molecules throughout the blood, but I'm sure you are aware, I'm sure you've heard of this before, but LDLs are sometimes called bad cholesterol, and HDLs are sometimes called good cholesterol. Well, why is that? Well, LDLs are bad cholesterol because they actually promote atherosclerosis. So LDLs are very susceptible to being captured by macrophages, which is why if you've got too many LDLs transporting around your fats, you're going to contribute greatly towards foam cell and plaque formation. HDLs are quite the opposite. They are more resistant to being captured by macrophages, and they actually have a tendency, once they have bound to lipids like cholesterol or fatty acids, they have a tendency to carry these away from the circulation and return them to the liver so that they can be metabolized and removed from the circulation. So another important issue here is that the liver has a lot more HDL receptors than it does LDL receptors. So HDLs are just much better at doing their job than LDLs. LDLs are not very good at their job by comparison, and they are much more likely to be captured by foam cells. captured by macrophages, which will then eventually become foam cells and contribute to plaque formation and atherosclerotic incidence. Okay, so now that we've had a chance to talk about that, let's talk specifics about how blood pressure is regulated. So back in chapter 19, we introduced the baroreceptor reflex, and we introduced that back then as a way of appreciating how cardiac output can be changed. So the whole baroreceptor reflex, we really focused on the afferent side of things. So for what reason would our autonomic nervous system want to regulate our cardiac output? Well, now that we can appreciate that the cardiac output is a major determinant of blood pressure, we can now revisit this baroreceptor reflex. So blood pressure, which of course is necessary to drive blood through the tissues, this is something that is going to be, that we need to regulate through homeostasis, just like a lot of other things, right? So we've talked before about these baroreceptors, these pressure receptors. We said they're located in the two best places to be monitoring blood pressure, the aorta and the carotid artery, and they project their sensory nerve fibers directly into the medulla oblongata, to those two cardiovascular control centers. And then from there, based on the information those control centers are receiving, they can make the determination, do we need a parasympathetic response or do we need a sympathetic response? So let's talk more specifics about what these baroreceptors are doing. Now, what you might be kind of expecting here based on previous discussions we've had, you might expect these baroreceptor sensory neurons to behave like this. When things are normal, you might expect them to be doing nothing at all, firing no action potentials whatsoever. Then when the blood pressure gets out of whack, then they start firing action potentials. That's not an unreasonable way of looking at it, because we have talked about things that operate like that previously. But the problem with doing it like that is that it allows the central nervous system no way of distinguishing between high blood pressure and low blood pressure. If you do it that way, the only two possibilities are normal blood pressure and abnormal blood pressure. We have to be able to distinguish between high blood pressure and low blood pressure in order for those cardiovascular control centers to make the right choice. Do we need to lower the blood pressure or do we need to raise the blood pressure? If the only information they're getting is that the blood pressure is abnormal, they're not going to know what kind of adjustment to make. So for that reason, that is not the way we are going to do it here. Rather, these baroreceptor sensory neurons are always going to be firing action potentials at a given frequency. So we said before that a normal mean arterial pressure might be somewhere around 100 millimeters mercury, like we see here. So even at normal blood pressure, these baroreceptor sensory neurons are sending action potential messages to the brain. So the medulla is always receiving messages basically saying the blood pressure is normal, the blood pressure is normal, the blood pressure is normal. It's receiving this information even when things are normal, and it's going to receive information when things become abnormal. So when the blood pressure starts to rise, these sensory neurons are going to become more depolarized, and the frequency of their action potentials is going to increase. So from the perspective of the medulla, who is receiving these afferent signals from these baroreceptor sensory neurons, when the frequency of these action potentials suddenly gets a lot faster, the medulla will interpret that as, okay, the blood pressure is getting really high now. I better engage the parasympathetic division to bring it back down. Similarly, when the blood pressure starts to get too low, these baroreceptors are going to become less depolarized, and the frequency of their action potentials is going to decrease. If the blood pressure gets way too low, then these sensory neurons will not get depolarized at all, and they will reach their resting membrane potential. And at that point, there's no action potentials at all. So again, from the medulla's perspective, when the frequency of the action potentials gets too low compared to the normal frequency at 100, then it's going to interpret that as, okay, the blood pressure is way too low. I need to engage the sympathetic division to bring it back up. So the frequency of these action potentials is directly correlated to how much these sensory receptors are being stretched by the shearing forces of the blood moving through the arteries. So the higher the blood pressure is, the more those stretching forces will be, the more depolarization these sensory neurons will experience, and the higher the frequency of the action potentials. So these signals are going to be sent directly to the medulla through both the vagus nerve and the glossopharyngeal nerve to the vasomotor control center, which is one of those two cardiovascular control centers in the medulla. But hopefully from looking at this, you can appreciate why these baroreceptor sensory neurons always need to be firing action potentials, because there's two different ways we can go. When the action potentials get faster, that's high blood pressure. When they get slower, that's low blood pressure. If no action potentials is your starting point, you only have up to go from there, and you cannot distinguish high from low blood pressure if you do it that way. Okay, so we actually looked at this exact figure back in chapter 19, but now is a good time to revisit this baroreceptor reflex. So you can actually see the location of your two sensory neuron receptor locations here. So we've got the baroreceptors here in the carotid and in the aorta. So through both the vagus nerve and the glossopharyngeal nerves, we send this afferent information directly into the vasomotor control center. We can send that information up to the cerebral cortex if we really need to, but really what's going to happen here is that the medulla, these cardiovascular control centers, are going to decide, do we need a parasympathetic response or do we need a sympathetic response? If the information we're getting from these afferent pathways is that the blood pressure is low, we are going to send that message down through the spinal cord through to an autonomic ganglion so we can project sympathetic fibers to increase the heart rate and increase the stroke volume. Cardiac output increases, and so does the blood pressure. If the blood pressure is too high, we will instead use a parasympathetic response going again through the vagus nerve to the SA and AV nodes to decrease heart rate, which brings the cardiac output down, reduces blood flow, and brings the blood pressure back down to normal levels. So you can kind of remember how these decisions get made here. If there's a fall in the blood pressure, we need a sympathetic response to bring it back up. If there is a rise in the blood pressure, we need a parasympathetic response to bring it back down. So let's look at a specific example of this baroreceptor reflex in action. This is something that you have no doubt experienced yourself. Say you're lying down in bed or you're sitting down on the couch, then suddenly you get up very fast. What's going to happen to you? You're going to feel dizzy momentarily. Why are you feeling dizzy? Well, you're feeling dizzy because there's not enough blood flowing into your brain, okay? But you'll notice that this dizziness does not last very long. Eventually you start to feel better and then you go about your business. So we need to explain exactly why you felt dizzy and why that dizziness only lasted for a short period of time. So when you go from a lying down position to a standing position very quickly, you are going from a position in which the force of gravity is not affecting your blood flow very much to a standing position in which gravity is going to want to pull blood down towards the lower half of your body. So with a whole bunch of extra blood being stuck in the lower part of your body in the veins, that is going to momentarily reduce your venous return. So with your venous return reduced, with not as much blood making it back to the right atrium, that is also going to reduce your end diastolic volume, which reduces your stroke volume and reduces your cardiac output. So for a few split seconds, your heart is not pumping out enough blood to satisfy the metabolic demands of the brain, and you start to feel dizzy because your brain is not getting enough blood and your blood pressure is momentarily too low to do that. So this drop in blood pressure that is a result of a drop in cardiac output, this is going to be detected by the baroreceptors in the aorta and the carotid that we mentioned before. They are going to reduce the frequency of their action potentials they send to the medulla. The medulla will recognize that drop in the blood pressure, organize a sympathetic response, send that message through those sympathetic fibers and also maybe through to the adrenal medulla to get epinephrine involved. And those signals, norepinephrine and epinephrine, are going to do three different things. Bind to the cells of the SA and AV nodes to increase heart rate, and that will increase cardiac output. Bind to the adrenergic receptors on the ventricular myocardium, increase your stroke volume, which increases cardiac output. And then the third thing we can do is vasoconstrict arterioles to increase total peripheral resistance, which is also going to increase the pressure of the blood moving through those vessels, because if you're increasing the resistance to flow, you've got to increase the pressure difference in order to keep driving blood through those vessels. Okay, so one thing that I want to make sure that we understand, since we just mentioned vasoconstriction and vasodilation, we want to make sure we understand the effect that vasoconstriction and vasodilation will have on blood pressure and blood flow. So we've said before that vasoconstriction and vasodilation will be most effective when it takes place in the arterioles. So think about something like this, where blood is flowing at a high pressure coming from the aorta, which you might see right here, and then the aorta will split off into a number of different arteries, which will then go on to nourish a number of different organs and tissues. So let's say that we have three different pathways that this arterial blood can take: here, here, and here. If we were to vasoconstrict the arteriole leading into this pathway, that pathway is going to experience a drastically reduced blood pressure. Again, because the resistance to blood flow past that constriction point has gotten very high, and that blood on that side is going to experience a drastic drop in pressure. Well, as a consequence, the upstream arterioles are going to then benefit greatly, meaning that the blood that otherwise would be going through this pathway here is instead going to be diverted to these pathways, so they will instead experience a higher blood pressure. So the idea here is that wherever your constriction point is, and again, that's going to be in an arteriole, vasoconstriction will increase the pressure upstream, meaning backwards, and decrease the pressure downstream, meaning forwards. And then obviously vasodilation would do the exact opposite. Increase the pressure downstream and decrease the pressure upstream. Increase the pressure upstream and decrease the pressure downstream. Okay, so let's look one more time at this whole vasoconstriction in the arterioles business. This is a very, very, very good diagram that I have been using for a number of years. I really like it. So we've talked about certain things before, so this is going to kind of split up the heart into a left side and a right side, and you can see the pulmonary capillaries exist in between them. So let's just focus on blood leaving as the stroke volume from the left ventricle out into the systemic circuit. So the aorta, as I said, is going to split up into a number of different arteries that are going to nourish a number of different tissues and organs. So look at these four different capillaries here. These four capillaries are going to represent the site of gas and nutrient exchange with major organs and tissues like the skin, the skeletal muscle, the brain, and maybe the kidneys, right? So if you imagine the idea of vasoconstriction and vasodilation as being like these little screws that can be tightened or loosened to regulate flow of fluid through these locations, then vasoconstricting the screws and vasodilation you could picture as loosening the screws to open up blood flow or reduce blood flow. So if you look at the leftmost arteriole, if we were to tighten that screw, blood can no longer flow through this capillary bed, but that blood that otherwise would be moving through there still has to go somewhere, so it is instead going to be diverted to these other three locations instead. So you can appreciate why it would be better to vasodilate and vasoconstrict the arterioles rather than the arteries, which are far upstream. If we do that, we run the risk of restricting blood flow to all four locations rather than just one of them. Okay, so I think that is going to do it for this video. I forgot to put a transition slide in here, so sorry about that. But join us next time for the last video in this chapter, and we are going to start talking about the microcirculation at the level of the capillary bed. So we're going to be talking about how fluid and materials get exchanged from the capillaries to the interstitial fluid as a means of exchanging things like nutrients and waste and fluids between the capillaries and the cells in the tissues that need that nourishment. So thank you for your attention, and I will see you next time.